Hi everyone, I am Francesca Cerutti, the member of Italiano Endodontics, and I would like to welcome you to this webinar we did in collaboration with Fanta about the endodontic management of unusual anatomies. So I recorded a short lecture that I would like to share with you, and please, if you have any questions, just write them in the comments, and I will answer at the end of the video. So thank you for being with us and enjoy.
Hi everyone, I am Francesca Cerutti, Gold member of Study Italiano Endodontics. Today I would like to share with you a short lecture about the endodontic management of unusual anatomies. We all know that in order to have a consistent and high level of success in endodontics, the first thing we have to do is to know and to understand the anatomy of the root canal system, because we have to shape, clean and fill entirely or as much as possible that root canal system in order to achieve the success. But sometimes it's not so easy to do it, because if we are not able to locate or to treat part of the anatomy of the tooth, our patient could develop a post-treatment disease and our therapy could evolve into a failure instead of becoming a success. So, the literature has widely investigated this topic, and the first problem is really to locate all of the root canal openings, for example. In this case, this lady had a sinus tract after the root canal treatment of the upper second left molar, and her dentist has seen her a lot of times, tried to fix the problem, but he never really was able to make the sinus tract disappear, and she has had it for months. Then she came and see me, and with the sinus tract, you see that the origin of the lesion is the medullary root of the second up molar. And what we could think about, why should this root be responsible for the failure? Well, maybe there is an MB2 in this canal. And so we take a CBCT, and yes, there is an untreated mesiobuccal 2 canal that probably is responsible part of this infection. So what do? I retreat the tooth. So the first thing is to remove the existing filling material, and we can do it in several ways, with heat, we can do it with mechanical files. You can choose what you prefer and what you are more confident with. And then the approach to this kind of root canal that is not so easy, because there is a curvature and it's a tooth that is difficult to treat because of the access, which is reduced. So I'm choosing files that are highly bendable but still have very good cutting efficiency. And my approach will be to pre-flare the coronal and middle third before trying to reach the working length. Why? Because I want to remove all of the coronal interferences that do not allow my files to go smoothly to the working length. And also I want to be as conservative as possible. So I do not force my files into the tooth. I just pre-flare up to 2506 in taper with the essential kit. Then with my manual 10K file, I go and do my glide path. I reach the working length, and then I use the 1303 file in order to do mechanically what I did with my manual K file. And then once I have reached the working length with my glide path file, I just have to choose the file that fits that root canal the most. So in the major canals, maybe I'm stopping to the 2506, also in the distal. In the MB2 I stopped to 20.04 because I don't want to enlarge it too much, because I don't want to sacrifice a lot of dentine. And in the palatal canal, which is larger, I can go up to 35.04. There is no problem. It's the anatomy of the tooth that suggests me which is the most appropriate file to treat it. And so this is the immediate post-operative. Then she went abroad and I've seen her 3 years later and she's like this. So the lesion has completely healed. And this is success, but only because I was able to locate all of the anatomy and to treat all of the anatomy. A careful inspection of our preoperative x-rays can really help us preoperatively in understanding how difficult the treatment will be and what we will expect. And then we will have to examine carefully and maybe with a thin probe try to find the root canal openings when we open the pulp chamber. We have to look at the pulp chamber floor. There is a color code that guides us towards the opening of the root canals. And we just have to follow that path. We have to be as conservative as possible because we do not want to remove with no need some dentine, because we do not want to weaken our tooth. We have to do the irrigation in the best way that we can because it's going to help us a lot. And then we do the three-dimensional filling of the root canal system in the way that we prefer and in the way that the tooth allows us to do. And then we just have to do the post-endo restoration and the follow-up x-rays. This is another example of missed anatomy, because sometimes we could think that molars are the most difficult teeth to treat, but if we look at the literature, we see that it's not true, and surprisingly, it's premolars. Premolars are the most difficult teeth to treat, because, first of all, they can have a high variability in their morphology, in their root numbers, in their root canal numbers. So let's see this case. It's a second upper premolar. Apparently it's an easy tooth because the literature said that it mainly has one root with 1 or 2 root canals, and the patient has had pain for like 3 months after the root canal therapy, and the pain is triggered by the percussion and by the cold. We see there's no perfect coronal restoration, there is some coronal leakage, but the pain to cold can be explained only in one way. So there is some vital pulp inside of that tooth, and I open the access cavity and I see that there was a completely missed canal. So with heat, I removed the existing gutta-percha, and now I'm retreating one canal and do the initial treatment on the other one. This was an easy tooth, so I could immediately go and get my working length with my K-file, and in this case, I use the wide and easy protocol suggested by Study Italiano Endodontics with the essential kit. Why? Because I have no coronal interfaces. So I can go straight to the working length with my 1303, 2004, 2506 and also 3504, because the root canals allow me to shape to that size and to the taper. And then I fill with the warm vertical compaction technique. And I suggested the patient to do an indirect restoration because in my opinion an onlay would have been the best choice for this tooth, but could not afford it, so I did a direct restoration and we will hope that the tooth survives over time. For that moment, 1 year later, everything is going fine and the patient has been symptom-free from the day of the retreatment. So the reason was a missed anatomy, missed root canal. As clinicians, we have to understand that there are some common variations from the norm in the anatomy of the root canals and in the anatomy of the teeth. For example, the MB2 canal in upper molars is a variation, but we find it in more than 90% of cases, so it's not so uncommon. Obviously, there also are some teeth that are extremely rare. For example, lower premolars with 3 or 4 root canals. That's a rare occurrence, but we have to know that that tooth could be in that way. Otherwise, we are not being able to treat it correctly. So, with Filippo Cardinali, many years ago, we did an article about the preoperative diagnosis of a third root canal in maxillary premolars. And what we know is that even if with different degrees of incidence, every tooth can have some anomaly in morphology. And what causes these anomalies is, for example, the ethnicity of the patient. Caucasians are different from Asian, they are different from people from other countries. Gender and age can have some influence because in some cases some anomaly can be seen more frequently in women or in men, and obviously what really changes the game is the way we have to evaluate the anatomy of teeth, because if I work with bidimensional x-rays, it will be more difficult to really understand and see the anatomy of the tooth. And if I'm working with a micro-CT or a CBCT or an extracted teeth, it's way easier for me to really understand how the anatomy is. So, we were talking about premolars. As a group, the maxillary premolars are a very common candidate for root canal treatment because they account for 15-20% of all the treated teeth. And over the years, the anatomy, internal and external anatomy of these teeth has been widely investigated using all of the techniques that you can think about. And talking about first premolars, in general, they have 2 roots and 2 root canals, while maxillary second premolars have 1 root with 1 or 2 root canals. But both premolars might have 3 roots with 3 root canals. So let's talk about numbers. Maxillary first premolar can have 1 root in almost 41.7% of cases, 2 root in 56.6%, and 3 root in 1.7%. And the different root canal morphology can be a single rooted premolar with type 3 canal configuration according to Bertucci, a 2-rooted premolar with top buccal canals and a single palatal canal, or a 3-rooted premolar with 3 root canals. We are talking about the classification of Bertucci, but there are other classifications that we are going to see later. About root fusion, we have to know that about 1/4 of multi-root teeth had root fusion, and 2-rooted premolars have a higher incidence of root fusion than 3-rooted premolars. In 3-rooted premolar, when there is root fusion, which is extremely rare, it can be either with the 2 buccal roots or all of the roots. When we talk about the number of root canals in maxillary first premolars, we see that the vast majority of first premolars has 2 root canals, while 11.2% of these teeth have only 1 root canal and 2.2 has 3 root canals. We saw the canal configuration by Bertucci. We all know it in its initial formulation. We also know that there were some variations over time. But then a new classification was done by Ahmed and colleagues, and it helps knowing in a more precise way about each root of the tooth we are considering, the number of root canals. So it's more descriptive as a classification. But about the canal configuration by Bertolucci, we can see that 64, almost 65% of maxillary first premolar have the type 4 canal configuration. Then there is type 2, followed by type 1 and by other configurations. Why is it important for us? Because we have to know how to shape the root canal. Because if there is confluence, I'm not treating the two canals that are merging until the working length, until the apex. I'm treating the main canal up to the working length and the second one up to the confluence. In this way, I am more conservative and also avoid file breakage. So it's very important to know that kind of data from the teeth that we are treating. And other investigation about maxillary first premolars were about the number of foramina. Most of them had 2 foramina and they hardly ever coincided with the apical root tip. And we also know that many of them, 38% had the lateral canals, 12.3% had apical deltas, and 16% had histamine. Why is that important? Because there is no endodontic file that is going to be able to treat an isthmus or an apical delta. So we will have to rely on a good irrigation and a good activation of the irrigant if we want to clean that portion of the root canal system. And then second premolars. Number of roots, mainly 1. So 78.8% of maxillary second premolars have just 1 root, but we can find 2 rooted and in a small percentage 3 rooted maxillary second premolars. And about the canal configuration, everything changes. So we have a vast majority of teeth with type 1 configuration of root canals, followed by type 4, others, and type 2. Another interesting thing that the literature tells us about maxillary second premolars is that the pulp chamber in general is at the level of the cementum enamel junction and that the roots are thin. So our shaping should be as conservative as possible in order to avoid mishaps during the treatment. So here is a premolar. Probably first premolar according to the shape of the crown. There is 1 premolar missing, the lady doesn't really remember, so I do the access cavity, I try to clean it, and as you can see, when I use my paper point, what do you see? From the palatal canal, you see the tip of my paper point, so there is a confluence that I spot while I was doing the shaping. So what did I do? I shaped only the main canal to the working length and then I cleaned, I did everything, I shaped the outer root canal up to the confluence, and the same will be done during my root canal obturation. So I will choose a master cone and then I can use an accessory cone to fill the other root canal or do it with the back filling directly, because the apical part is already closed, and I also do the back filling of the confluent canal. And so I did my post-endodontic restoration with an indirect restoration. This is a composite only. And then, since the first molar had the not perfect restoration, I also did a direct restoration on the first molar. And then I refer the patient for periodontal treatment because you saw there was a periodontal puppet. So she needs other treatment, not only the endo. And here is a completely different case. So we have a premolar, we have already removed the decay, so we have an outline of our access cavity. This was a caries-driven access, but we always have to remember that the instrument might have a straight line access to the root canal. We do not want to have coronal interferences because, first of all, our instruments are working better are more performing if we do not have coronal interfaces. Second, if my instrument has a straight line axis, it will follow better the original path of the root canal, and I will avoid to stress my instrument and to do perhaps to enlarge too much the middle third of the root canal, to straighten up some curvature, etc. So what did I do? I did some pre-flaring, so I worked short to working length with the first 3 files of my essential kit sequence. Then I recorded the working length, and then I go straight to working length with number 13, with number 20. I do, you see, 4 or 5 strokes, and then I rinse and I change my file. 1, 2, 3. I use a picking motion, maybe some brushing, but the main motion is picking. I arrive to my working length, good. If I'm not, I'm working again with the file. And then once I did this thing on one root canal, I do the same on the other root canal. I go with my 1303 first. When I have reached the working length, I go with my 2004. I'm using the files at 400 rounds per minute, according to the manufacturer's instructions. I do not want to invent anything. I want the file to work at its best. Picking motion, and then I change the file, and I go with my 2506. In this case, when I remove the file from the root canal, I check the spires, and if I see fresh white dentine on the spires of the file, there is no need to enlarge more. It's a visual gauging procedure. So what do? I do the irrigation, and I activate the irrigant with ultrasonics. You can use sonics, you can use whatever you want to. The important thing is to make your irrigant work at the best. And then I do the 3D filling of the root canal. And as you can see, this is one premolar with 2 root canals and a lateral canal that I fill with my sealer. And this, you can see that I see a root canal, and then 1, 2, and 3. This is a rare occurrence, but if I see this in my preoperative radiography, I have to change completely my approach to the root canal treatment, because I have to change my access cavity, I have to change the shaping, the cleaning, the filling procedure. So one thinks, okay, this is about maxillary premolars, so mandibular premolars will be easier to treat because their anatomy is easier. It's one root canal, it's kind of straight as a root, no abrupt curvatures, everything is easier than in maxillary premolar. Well, unfortunately, the answer is no, because on multiple occasions, mandibular premolars have been stated as the most challenging teeth to be treated endodontically, especially when they present multiple roots or multiple root canals. Why are they so difficult? Because they have a lot of anomalous variation. They can change broadly. They also have a narrow access to the root canals and a narrow major distal dimension. So for us, it's extremely difficult to see what we are doing, which is the first main problem in endodontics, because how can I treat something that I do not see properly? And they can have a lot of apical third bifurcation, trifurcation deltas. And then if you have the armamentarium, no microscope and no skills, it's extremely difficult to treat correctly this kind of teeth. So a recently published systematic review of the literature summarized that lower bicuspids commonly have one single root. In more than 97% of cases, lower premolars are easy with mandibular first premolars being twice more likely to present two canals than second premolars. And we can also find a small number of cases in which we have multiplicity of roots and root canals. So watch out, because they seem to be easy, but in some cases they are extremely difficult. So talking about numbers, mandibular first premolar have one root canal in 67-86% of cases, two canals in 15-25, and three canals in 0-30% of the cases reported in the literature. Mandibular second premolars can have three canals only in the 0 or 8% of cases, dependently on the study you are considering. So they are not really frequent to find. But if you find them, how are you going to approach the case? First, clinical examination. Even before taking an X-ray, look at the tooth and try to find out if there is something strange. Second, try to read as carefully as you can the X-ray. Third, do a proper access cavity, because if you don't do the access cavity in the right way, we are going to miss everything. 4. Try to inspect the pulp chamber floor to locate the canal orifices. Try to have the best vision that you can, so light, magnification, and if you can, use an advanced imaging technique such as the CBCT that can help you a lot in understanding the anatomy in complex cases. And also, take your time. But we will see everything in detail. When you look at the coronal and radicular morphology of teeth, you know you have some landmarks. And when you see that the dimensions of the crown do not fit with what you usually see, then you can start thinking that could be something uncommon in the root canal morphology. If you have an additional cusp, if you have tubercles, if you have deep developmental grooves, you can think about a bit of a bifurcation of the root. And if you see fusion of teeth, you can think you are going to have a strange root morphology. So, one other thing you can do is to do probing, because you can see if there are furcations, you can see if there are some deep grooves, and if you see that there is a gingival recession, maybe you are going to see the morphology of the furcation of two roots in a tooth that maybe had one and you thought had one. So try to probe the buccal surface in order to examine and see if there is some bifurcation of the root, or there is some hint that can help you identify the presence of an anomalous root morphology. And then when you take the X-ray, look at the X-rays, because in general you see that the premolar have a thin root in the middle third, and this dimension is smaller than the dimension of the crown. When you see that the middle third of the root is larger than the mesiodistal size of the crown, then think about more than one root. And also, as I showed you before, a sudden change in the radiographic density of the root canal space usually corresponds to a bifurcation of the root or to an additional canal. If a radiography shows a disappearing of the pulse space, the canal is diverging into parts that may be separated, or maybe they are merging later, but in that point they are separating, so you have to do your cavity access and your shaping accordingly. And also, when you suspect that there is a strange root canal morphology, try to take X-ray with different angulations in order to show you what maybe has been hidden in the first radiography. And in this case, for example, I didn't have the necessity to do a different angulated radiography because first I saw a strange profile of the root of the first lower premolar. This patient was treated by a colleague, and since the day of the treatment she has had pain to cold to percussion. Then the pain to cold slightly disappeared, but she still had a lot of pain when I saw her. And I asked my colleague, since there was a missing tooth nearby, did you take a CBCT for placing an implant? He said, yes. So please send it to me. And what do you see? Look at the anatomy of this root. There were 2 separate root canals. And look at the shape of the root. You can imagine this shape from the preoperative X-ray if your eyes are a little trained. But obviously you see it way better in the CBCT. And in this case, if he had looked at the CBCT that he took before doing the root canal treatment, he would not have missed the root canal. And when I opened it, I did a selective retreatment because I considered that the first root had been treated correctly. So I treated the other root canal, and as you can see, I did the same sequence that I used before. So I did a pre-flaring, a glide path, and then a shaping and finishing until I reached the 2506, because it was enough for me to shape, clean and fill the root canal system. I treated the patient, I sent her back to the colleague for the prosthodontic restoration, and I have a 6-month follow-up X-ray where everything is working correctly. And you see the 2 separate root canals in this lower premolar that was supposed to be easy as a tooth. But obviously, if I want to see something, I have to make my access cavity the better responding to the anatomy of the pulp chamber. So, for example, if I'm used to do an access cavity in premolars that is like an oval-shaped access cavity, if I am thinking that there could be some variation, I have to make it more triangular. Because if I think that there are 2 roots or 2 root canals buccally, then I have to make room for my eyes to see those openings. So my access cavity will be triangular. So I share with you a case of a patient that I saw in an emergency, and she had pain with hot, with cold, with percussion. She had a recent root canal treatment on the first molar, she had a pulpotomy on the second molar, and she has a decay on the second premolar. And which tooth is responsible for which problem? The pain provoked by cold is the second premolar, because there's vital inflamed pulp in it. The pain to hot is the second molar that had been opened in some way but had not received the correct endodontic treatment. And the pain to percussion is the first molar because there is a lesion. Okay, but how often can we find 3 canals in maxillary premolars? According to Vertucci, the second premolar is 1%. According to Pineri and Cutler, 0. According to Carter et al., 0.7. According to Pecora and colleagues, 0.3. So I was extremely lucky to find the 3 root canals in a maxillary second premolar. I did the retreatment of the molar, the initial treatment on the second molar, and then I took my time to treat the second premolar. I checked my working length, I did my obturation, and then she went back to her dentist for the restoration, and you see there is an endo success because the lesion on the first molar healed and the restorative failure because the crowns, I don't like them. And what happened? That I saw her 1 year later to do the second x-ray, and there is a deep decay on the first premolar that, surprise, has 3 root canals and 3 roots. And it was opened by a colleague that did that kind of access. The first you see on the left of the screen. So the regular access you do on a premolar, oval shaped, because she was not able to read correctly the x-ray that was screaming, I have 3 roots and 3 root canals. So I corrected the access cavity. As you can see in the second picture, it is triangular, T-shaped as an access cavity, and you see there was 3 root canals. Same sequence as before, but I stopped to the 2004 because the roots were extremely thin and I did not want to over-enlarge or to break a file. And then I did the root end filling with the bioconeless technique, and I did a direct restoration on the first premolar. And one nice thing is that the rarer the anatomy, the rarer the case, the more frequently the patient has the same anatomy on the other side. So, in this case, probably I will do another 2 root canals if she doesn't take care properly of the decays that she has on the left part of her mouth. But one really important point in managing endodontically complex anatomies is to see better what we are doing. So we need magnification and we need a coherent coaxial light. So without a microscope, some anatomies cannot be treated correctly. With loops and a light, you can treat most of them, but you need at least loops and light. Obviously with the microscope it's easier because we are seeing better, but also if we have more room to see what we are doing, we can work extremely better. For this reason I like this tool, because in some cases it's really game changer, because you can mount your number 10, number 8, whatever you want, K-file on this handle that is called C handle, and what you do, you pre-bend the file with tweezers, with your fingers, with whatever you want. You choose your favorite file and then you put it into the handle and you screw the handle on the tip. In this way you secure the file to the handle and you can use it as you were using your own hands, because sometimes we cannot really see what we are doing if we have our hands that block all of the space of the access cavity. If we are using a handle, we have improved visibility because there is not the head of the K-file and our finger between us and the cavity. So we can see directly what you're trying to do, and also the plus is that we can connect our apex locator to the handle and it's going to tell you if you are at the working length, you're short, you're long. So it's really time saving and sometimes extremely helpful to have this kind of tool when you treat complex anatomies. And what about working length? Well, sometimes if I'm taking an X-ray, it's difficult because of the superimposition of structures to see if I am in the correct place with my files. So in complex anatomy, maybe we can trust more our apex locator than our intraoperative X-ray. What happens if we take an intraoperative X-ray and we see our K-file that is completely off of the center of the tooth. Well, in that case, we can intraoperatively suspect that there is another root canal, and so maybe we have to enlarge our access cavity and search for one more root canal opening. And what about the shaping? What about the preparation? We can be extremely careful, and we have to pay attention to two things. The first are curvatures, and the second is the thickness of the dentine. About curvatures, we know that in unusual anatomies we can have sharp curvatures, above all in bifurcation or trifurcation areas. So in maxillary premolars we can have them, but way more we can have them in mandibular premolars. In that extremely small percentage of cases where we have bigger trifurcations. In that case, we have to prevent file breakage. And how do we prevent file breakage? First of all, as I said before, the coronal preflaring, because I want that only a small portion of my file works every time I'm using it. I do not want my endodontic file to work for its entire length. Otherwise, the stress concentrating on that file will be extremely high. I can pre-bend hand files in order to follow better the curvatures of the tooth, and of course use fresh night eye files. Use brand new night eye files. Do not reuse them after having treated a difficult tooth, and in the same way do not take a file that has worked for 6, 7, 8 root canals and use them in a complex anatomy, because in that case the chance for that file to break become extremely higher. When you have curvatures, you can also consider to manage them directly with rotary files. The important thing is that you avoid to apply any kind of pressure to the file. You do not have to force it into the canal, otherwise it will break or it will create a block. The best that you can do is to do multiple approaches with 4 or 5 strokes and then remove the file, clean the spires and go again. And as I said before, clear flare, remove the coronal interferences and then use a small file, go to the working length. After you have reached the working length with a small file, you can pass to a larger file. What about the thickness of the root dentine? We have to be extremely careful in these complex anatomies because the dentine that is surrounding the root canal is extremely thin. It's in a small layer, so we do not have to over-instrument it. We do not have to apply some brushing movement, otherwise we are removing some dentine that we do not need to remove, and we risk to make strippings or lateral perforation if we do not pay a lot of attention to this topic. In the same way, we have to be extremely careful when we choose our obturation technique if we have thin root walls, because when we use worm gutta-percha compaction techniques or worm techniques in general, we have to remove some dentine in order to make room to fit our heat carrier, the pluggers, the backfilling device, etc. So maybe in some case it's preferable to use cold techniques like single cone bioceramics or lateral compaction technique, because we are stressing less the tooth, and also because if we apply too much heat, if the dentine is thin, we can create a damage to the supporting periradicular tissues. So let's pay attention to this. And last but not least, take your time, because the time that it takes you to treat a complex case is really depending on your clinical experience, how many cases like that you have treated before, your skills, the armamentarium that you have. So do not be afraid if you need more than one appointment to finish such a tooth, because sometimes if you rush, you make mistakes, and then it's a bigger problem. And then the obturation. As we said before, the literature suggests in complex cases the lateral compaction, the Hebrew technique, the vertical compaction. What I suggest and what some other articles support is to use a single cone plus bioceramic sealer in extremely complex root anatomies where you do not want or you do not have the room to fit your heat carrier to up to 4 millimeters from the working length, for example, or the roots are thin and you do not want to push with your pluggers. In another situation, you can use the coneless or bioconeless technique. If you can fit your backfilling device and you have a strong and firm reference, you can backfill the whole root canal system without using the heat carrier, which is an advantage. Or you can also use the vertical compaction. It really depends on the size of your preparation and on the anatomy of the tooth. But the more complex the anatomy, the more likely is that you are going to need to make some modification of the technique of obturation you want to use. And then one last case, another mandibular premolar, in which from the preoperative x-ray you could guess there is something that is not normal. In fact, there are two deep decays. I do a multiple isolation because I have to treat both premolars. I open my access cavity and what do I see? Two root canal openings. And the pulp change bell floor is telling it clearly because I have one line that guides me once I have found one root canal opening toward the second one. And if we remember the Krasner and Ranko symmetry law, that's symmetric. I found one root canal opening and on the other side another root canal opening. So I will have to deal with the lower premolar with two root canals. Perfect. Fine. I take my working length, I try to be as conservative as possible in my shaping, I'm clean, and then what do? Pre-flaring, glide path, shaping and finishing with a small file, 2004. And in this case, I chose a single cone and bioceramic sealer filling because the roots are thin. I have no good access, so I don't want to risk it. I use the easiest technique. Then I do a build-up because I'm doing an indirect restoration on the first premolar, and then I do a direct pulp capping on the second premolar, direct restoration, and I lute my onlay. And that's the result. So I hope you enjoyed this short lecture, and I thank you very much for listening.
So thank you for watching. I hope you enjoyed the lecture. And I see there are no questions for the moment, but if you just need some more time to elaborate, then you can write them below or write to me directly on Italiano Endodontics and I will try to answer. And if you missed the lecture, don't worry because we will be publishing it in the Pop Dentistry website soon. So you will be able to watch it again if you missed some part. I hope you learned something about the management of unusual anatomies, but the important thing is really to be aware of what you are about to face when you try to treat such cases. So, first of all, please take your time to watch the preoperative x-ray. Because with a good periapical preoperative x-ray, you just can have the idea. And if you follow the list of guidelines I give you, I'm sure you will be able to identify and to manage even these weird anatomies. So thanks again for watching and bye bye.